During the 1980s, when large numbers of gay, bisexual, and men who have sex with men, or MSMs, were losing their lives to HIV, a popular belief was HIV was primarily a gay, white man's disease. And yet, HIV's impact was felt through all racial groups. Now, 30 years into the epidemic, African Americans and Latinos are more likely than whites to die earlier from AIDS. Hello, and welcome to HIV at the Crossroads. I'm Duran Rutledge with the California STD HIV Prevention Training Center. In this episode of HIV at the Crossroads, we'll discuss some of the critical challenges facing HIV-positive MSM of color and what can be done to address some of those challenges from a physician's perspective. Joining us today is Dr. Anthony Jones, who has served as a staff physician at Contra Costa County Health Services for 10 years in their HIV care program. He is a board-certified family practitioner and an HIV specialist currently practicing in Oakland. Also joining us is Dr. Damon Francis, Medical Director of Healthcare for the Homeless in Alameda County. He is also an assistant clinical professor at UCSF. Both of our panelists have worked extensively with HIV-positive MSM of color, and I welcome you both to the panel.
Thanks.
You know, access to healthcare is a critical component of, HIV care. Anthony, Dr. Jones, is there a greater challenge facing MSM of color that makes it more difficult for them to access healthcare? And if so, what are some of those challenges?
Certainly for MSM of color, accessing healthcare is a tremendous obstacle in some instances. We know for people of color, accessing healthcare in general can be more challenging because they tend to be underinsured or are more likely to not have insurance. And so, first of all, having insurance and being able to see a provider and enter into the healthcare arena is a challenge, particularly for men of color and MSM of color. Accessing a healthcare environment where they can be seen and not feel stigmatized or judged is a particular challenge for those individuals.
And how do you address some of those challenges that you just mentioned as far as stigma and accessing healthcare?
In many instances, we have to be a little creative, and in some cases that can even include having programs that are in place to help link those individuals into care. And also another approach would be to have the healthcare come to them or have healthcare establishments in the communities that are less likely to interface.
And I'm going to throw this out to you, Dr. Francis. So how vital is it, the relationship with the patient and the physician?
Well, just to follow up a little bit on what Anthony was talking about, I think it's really crucial that we remember the real structural factors, the health insurance problem, the fact that there's a shortage of providers in cities like Oakland to even serve the numbers of people who are there. So access needs to be addressed at that structural level, absolutely. Then also we need to address it in our own practices and in the things we do with patients by building relationships with them. And for most of my patients, it's really, really important, the relationship I have with them, but I do have a few on either side. I have someone who is employed, has a very high-paying job, couple dogs, nice lifestyle. It doesn't much matter to him who his physician is, I don't think, to his HIV outcomes. We have a good relationship, but I think he's going to do well no matter where he is. Okay. I have other patients, though, on the other end where the relationship with the physician or the treating practitioner is critical because they have a belief that HIV medicines don't work. They have a number of other factors that are more important to them in their life right now in this moment than HIV, and they're not going to start listening to me until I start developing a relationship with them, until they can really feel that I understand the circumstances of their life. Then maybe we can get to working on, okay, you're gonna take a med every day and you're gonna come check in with me and we're gonna start working on this problem together because you understand that I'm fitting it into the rest of your life.
Okay. And you mentioned something that was really kind of critical, I think, with the whole kind of move towards the healthcare reform and the national HIV/AIDS strategy. How do structural hospital, policies affect how you serve individuals? Damon, Dr. Francis, you mentioned that you may have an individual that has insurance, and I know that you have to work with individuals that may work with individuals who don't. So with the National AIDS Strategy that is trying to get more folks into linked to care, and with the healthcare reform that's trying to kind of bring down or level the cost of healthcare, how do you see that impacting, or does it impact? How will it impact how you provide healthcare?
Well, I think at a very high level that the Affordable Care Act and the expansion of healthcare coverage is a really, really good thing for many of our patients. One of the groups of people most likely to be uninsured was poor men of color, because a lot of the Medicaid program, Medi-Cal in California requires you're poor and you have some other factor that makes you eligible for Medicaid currently, which for many, many, many people is linkage to a dependent child. And many men don't have that, and as a result, they're not eligible for public coverage for the Medicaid program nationally, Medi-Cal in California right now. I think the expansion of that is a really, really huge deal. It's going to mean that a lot of the folks that we see who are men, and who are men of color, and who are poor men of color, now have access to insurance that can pay for a lot of the services that we need in order to keep someone with HIV healthy.
Okay. I completely agree with everything that Dr. Francis has said here. One of the factors that will probably pose a bit of a challenge will be resources, in that we only have so many providers, and certainly there's a relative shortage of providers who are skilled in HIV care, and certainly it's great to have coverage for those individuals so that they can access care, but we really need providers waiting to receive them to give them appropriate and high quality care at the same time. And certainly within the healthcare industry, or working as a practitioner, one of our biggest challenges is time. And this is a condition that's very complex and has lots of implications for people's lives. And in building the relationships, as Dr. Francis mentioned, it takes a lot of interaction, and that's a little bit of a premium there.
Okay. Dr. Jones, you mentioned something about as far as time. I know that a lot of the individuals, MSM of colors, there's a number of health disparities. An individual might be homeless, there might be some type of mental health component. I'm not saying all, but maybe some of the individuals that you serve. So when you talk about, a component of time, how do you address some of those challenges in addition to addressing their HIV care?
Excellent question. And certainly the way that's proven most successful in the past is to rally additional resources in the form of help. Oftentimes we'll take a multidisciplinary approach to providing care for these individuals with case managers, mental health advocacy workers, and other organizations, in some cases community-based organizations that provide support for these individuals and can bring them to their doctor's visits, can go home and do follow-up education, and kind of fill in that gap where we as providers, we only have so much time to give patients, and we have a lot of information, but we don't have all the information. So it's certainly, I think in most cases, it's most effective to have a team providing that care to individuals and have the best chance for success in that sense.
And what would you guys say to a new physician who's going to be working with MSM of color? You guys have extensive history in working with MSM of color, and it sounds like you're very effective in kind of addressing some of those health concerns. What would you tell a new physician who's going to be working with the target population of MSM of color?
Certainly. There are approaches that are universally applicable in medicine, and those approaches involve non-judgmentalism, open-mindedness, and really partnering with your patient to try to meet a common goal, and that being good health care on their part. And so I would encourage new physicians, as I used to when I was teaching residents, to listen to their patients and to engage them and have them be convinced that you're on the same side. Mm-hmm. And that often takes a few visits, and it's a process. And certainly in populations that are disenfranchised or marginalized, it can be a little bit more of a challenge. And so, certainly to listen and to ask questions in a non-judgmental way, and to follow through and to be true to your word in a lot of cases. And so I think just and all those principles are universally applicable, as I said, but I think they're particularly important when you're trying to build trust. And this is a community that's really been, had challenges with accessing healthcare, and I think that trust is a big part of it.
You know, and I just want to transition us to kind of a different topic, and that's like HIV-related stigma. You know, Dr. Francis, you mentioned it a little bit earlier, but I just wonder how have you seen HIV stigma or stigma just in general impact how your clients, you know, access healthcare?
I have some patients who, at this point, cannot say the words that they have HIV. Okay. It's a thought that makes them very uncomfortable and thereby does complicate their accessing health care. There are some individuals that do not want to go to certain clinics because of fear of being associated with the care that's being provided in those locations. And so when you have such a divide and such a sensitivity for or an aversion to the fear of being associated, that stigma runs quite deep, and it provides a big barrier and a big challenge for a lot of our patients. And I think in that sense, a lot of times we have to be creative in that sense. And some patients, they access healthcare in non-traditional locations or off hours and other types of situations like that to try to make it a little bit more comfortable for them.
Okay. So, and, you know, and I'm going to throw this out to you, Dr. Francis. So, Dr. Jones mentioned having to be creative. I know that there are individuals, if HIV is in the name of the organization, that they may not choose to go to that particular location just because of the name. Mm-hmm. So how have you been able to combat some of that stigma?
Well, we've got some real stories of creativity. We have people who show up in costume, okay. People who wait in different waiting rooms. You know, a lot of patients who can come in every once in a while, but it's really hard for them. We've managed to work out, to deal with their stigma, we've managed to work out kind of doing more care over the phone, get a lab at an outside lab, I can see the results, you're basically okay, we can talk about things over the phone, we can minimize the number of times you have to actually come here, and you know, given that the physical exam may not necessarily for you be a crucial part of your care, can I work with you so that we can come up with a plan to do some of this stuff by phone. I think internalized stigma is a really big deal, and mm-hmm. then I think also external stigma is a really, really big deal. I think that my patients who find a way and a person to disclose their HIV status to just do better. And I still, even though we talk about it, I bring it up in a non-judgmental way. There are a good number of folks I've seen who haven't disclosed to a single person outside of the care team that's providing care for them that they have HIV, and that's as a result of stigma. I mean, there's some horrible stories. One of my patients, family members, would exclude her from parts of family life basically because of her status, and it's really hard for the medicines to work or for us to solve someone's HIV problems when that's what's going on for them when they're in the family or in the community.
You had mentioned like external and internal and external stigma. Mm-hmm. Can you say just a little bit more?
Well, I had a newly diagnosed patient a few months back, and he said, I feel dirty with this.
Okay.
I feel like I'm dirty. I feel like I'm wrong. I feel like I'm bad, and that feeling, without being able to be expressed, or if someone can't cope with it, becomes really, really detrimental to their emotional life and their mood, and makes it really, really hard to stay on time with your appointments, do all the care you need to do, take all the medicines you need to take. So you see internalized stigma in that way about the disease. Sometimes you see internalized stigma related to homosexuality, mm-hmm. which I've seen a lot in very religious families, for example. And there's a young gay black man who doesn't really have any acknowledgement of that lifestyle being okay and positive and great in his life, and carrying that I'm not a godly person in a family and a society where God's really important. So that internalized stigma can be really crucial. And then when people are saying that around you, it's not safe for me to disclose this. And it really isn't, mm-hmm. in many cases, safe for people to disclose their status or safe for people to own their sexuality.
So it sounds like from how you guys are describing it, stigma can definitely impact how an individual kind of works with their physician and or how that kind of impacts their overall health, whether it's, as you said, like the internal or external kind of feeling of stigma. I'm also wondering how that actually kind of plays into like additional support for the individual? I know that you guys are very limited in the amount of time that you can actually spend with somebody, and that's pretty major if someone has that kind of internal or external, the way that you describe it. So what happens, or what would you suggest should happen or could happen for that individual to help them address some of that internal and external stigma, so that when they come to you guys, that their healthcare is more, it's more beneficial, it's doing what it's supposed to do. You move on from that point to really kind of making sure they're engaged in care.
I completely agree with something that Dr. Francis mentioned earlier. With patients, and oftentimes early on with their coming to know about their diagnosis, I encourage them to think of a person who they could disclose to and feel safe disclosing to. In that sense, it can allow them to share that burden and to not feel isolated. With the stigma comes an intense sense of isolation and aloneness, and it's easier for some of those negative emotions to kind of spiral. And that definitely has a deleterious effect on their health and their mental well-being. And so even if they don't tell them, I encourage them to think of someone. It can be a family member, it can be a coworker or a friend or someone that they trust. And although it's a process for many, most will eventually get there. There are also, in some cases, anonymous support groups that people can go to, just to kind of to be in the presence of others who may be having a shared experience. And oftentimes people will come away from that experience saying that they feel a little bit lighter from having gone through it, and they really do not feel as isolated. And so I think of approaches like these to try to help lighten the load a little bit for people. And it's really a process for people to come to terms with their condition, to own it, and then to take responsibility and be more aggressive and participate in managing it.
Okay.
On the spectrum of those, your own friend, your own coworker, someone in your life, or family member, I think even formalizing that with the peer navigator, in the clinic when people can't find someone like that, just having someone who can relate. Certainly at East Bay AIDS Center where I did my fellowship, we had several peers who really, in my eyes, were the major factor that led someone to treatment success, being the person that they could disclose to who did understand their situation. And so I'm a big advocate of formalizing that a little bit in the clinic setting, paying for it, which is another big deal.
Certainly.
Right.
And I want to transition us to like next steps. I think when you talk about peer advocates, that sounds like something that could really kind of benefit an MSM of color, anyone, in kind of connecting to healthcare and also dealing with some of the stigma associated with being HIV positive. What do you guys see as, some next steps, or some, what the future may look like for MSM of color trying to are accessing healthcare?
Well, I think that certainly we've been in a situation with this condition for quite a long time at this point, and we haven't made nearly as much success as we would like to have, and we probably should have. And so I think that our next big breakthrough will probably come in the social sciences arena. We really have to change the perception of HIV as an illness which some refer to, as Dr. Francis said, as dirty, and many people still think it's a death sentence, even in this day and age. And when we know that there are very effective medications that can give a person a normal lifespan, they can do family planning, they can participate in life like everyone else. And so I think we really have to get that message out and have that message be received and believed by the population, which is not receiving that message now. And I don't know that we know how to do that. At this point, a lot of people that are affected and continue to be affected and continue to be diagnosed have not gotten the message as it's been given out up to now. And so I think we have to reinvent our conversation about HIV and really see it for the chronic, potentially lifelong medical condition that it is. And at the same time, there's lots of new information about treating HIV and other approaches that can help to curb the transmission of HIV. And so we have to take a step back, I think, and really regroup and reapproach with those things in mind.
Okay.
Yeah, I agree. I think we're going to see some things like, advances in immunizations, advances in cure research, advances in social science. The science of this is going to really help. And I think much, much more important than that is the social justice and human rights component of this. I think thinking that we're going to get a long way with HIV without having addressed homelessness and poverty and drug use and all the other stuff you mentioned earlier is kind of silly. And what we've seen a lot of scientific advancement in HIV. It's terrific to have these pills in our pocket when we're in clinic, and we're still facing many situations in patients where it's just not enough. And so I think we do have to have a focus in that area.
And I know that when someone tests positive, at a test site, and then they may get linked to care through the linkage coordinator at one of the community-based organizations. So what do you think those in the field could do to help better prepare someone who just tested positive to make them prepared to link to care?
Addressing linkage to care and addressing connection to healthcare services needs to be done the same way that we need to do our healthcare services themselves, which is in a very client-centered way.
Okay.
The most important thing to do with the new diagnosis of HIV is listen. By far, much more important than any information that you're transmitting is what information you're receiving. And then I think, in addition, the skill set that case managers and testers and doctors need to have is partnership, collaboration, coordination across the community. As Anthony said, rightly so earlier, we don't do this by ourselves. We do it in a team, and understanding who your teammates are, what their skill sets are, what agency might be able to help in a situation where you can't is absolutely crucial, not just feeling like, okay, I have to deal with this myself.
And when you say, as far as working together, as far as a team, so how do you put together that effective team to be able to, have somebody's tested, the linkage coordinator, and from the linkage coordinator to the physician into an undetectable viral load, and that the individual is successfully leaving with HIV? As you said, it's not a death sentence. I mean, how do you put together those teams?
First, you have to have all the ingredients and all the players
Okay.
on the same court, and there has to be a lot of communication amongst those players, and so people have to and be poised and ready to play their part, I would say. And so for us to be in conversation with these other individuals and for them to be the eyes and ears for us out in the community in interacting with clients and patients, I think that we have to kind of know our positions. And I was going to say on the piece before that it's really a pivotal time for people. That moment when they're diagnosed, they'll probably feel the most alone at that moment. And so if that linkage person or that tester is the first person aside from themselves who knows their situation, if they can be made to feel safe in that moment and know that they're going to be okay, let that support start at that point. And so I think that certainly healthcare is very complex. There are a lot of moving parts to it, and so we have to really communicate often and share a lot of information to try to really keep a patient-client focus and all do our part, I'd say.
Yeah.
Okay.
Just to build on the metaphor, you have the court. You have to actually build the court. We need the structural pieces in place in order to have that team function. What we've had for a long time in the United States, the Ryan White Care Act, and some of the other state and federal level funding that's allowed us to be creative and do teamwork with HIV. We need to preserve those pieces of policy that really allow us to continue to have a team, not just think, okay, we have a doctor, we're paying the doctor for a 20-minute visit, that's going to solve HIV. And so I think it's really crucial that we support that team that Anthony was talking about, how you build.
And does the National HIV/AIDS Strategy, is that going to help build that team, do you think?
I certainly hope.
Okay.
I think there's potential. I mean, certainly it's a starting point, if nothing else. And I think by raising awareness and getting people tested and people knowing their status, certainly if there is an acknowledgement that there's a need for more resources and more team members than we have, there'll be opportunities in the future to try to bolster this system and maybe learn as we go along. But I think it's a huge opportunity to really maybe make more progress than we've ever made before, certainly in this population.
And how do you see HIV changing over the next 30 years?
Well, I was talking to a doctor who's been in the HIV community for a long time, and he talked about at the beginning of the HIV epidemic how they swapped one drug out and put another one in, and then swapped one drug out and put another one in, and how it didn't work. And then they started putting 3 drugs together, and it worked. And he uses the same paradigm to think about what we're doing about HIV. We've created a pretty big community-based organization and behavioral infrastructure for those wraparound services, and now we've started to get some biomedical tools, treatment as prevention, even medical prevention, right? I give you a medicine and that prevents you acquiring HIV. And he says it would be silly right now for us to swap one in for the other one, that we need to maintain that community infrastructure that we've worked so hard to create and bring to it the biomedical focus. And I think to the extent that we can do that in our policy and in our own programs that we're on the ground working in, I think we'll be more successful.
Okay.
I'd say maybe also starting to rewrite the perception of HIV itself. Hopefully in 30 years we'll think of HIV like we do hypertension or diabetes. It's a condition that exists in society, or actually hopefully there'll be a cure by then, but should it exist in society, it would be easily treated and successfully treated, and there wouldn't be all the associated stigma and other factors that get in the way of treatment.
Okay. And you see that, do you think that there will come a time that HIV medication, instead of like a daily medication, might be something that's like once a week, once a month, or?
I think there'll be a time when there's a cure, and I'm pretty excited about some of the research that's happening right now. I think it's really hard to predict when that's going to be, but I do hope it's in my lifetime, and I think that there are a lot of really creative people doing great research now.
Right. As Dr. Francis said earlier, there's lots of cutting-edge research that's happening now, and to some degree, the advancements are kind of escalating, and they're even looking at some agents that can last a week or longer. And so that may very well be something that we have in our toolkit in the future.
I want to thank both of our panelists, Dr. Damon Francis and Dr. Anthony Jones, and I hope that you enjoyed this segment of HIV at the Crossroads, and I hope that you found it enlightening. I'm Duran Rutledge. Thank you for watching.